I call the member for Bowman.
Deputy Speaker, Australia has indeed a fine history in public health. It's worth recounting briefly as we debate the bill. And as we consider the future of the Preventive Health Agency in this country, it's another example of yet another agency, well-meaning, filled with talented and committed people, but which was ultimately unaffordable. For ANPA, in the years that it existed, failed to carve out its own space, supported by states and territories, its information not requested by other jurisdictions, and ultimately there is a certain impotence about collecting data for which no one uses. One of the great frustrations in the health system is up to a dozen data collecting agencies, and that can't be good for managing an individual's health, no doubt. Of course, we know that over time public health has shifted its emphasis from infectious disease more so now to diseases of lifestyle, obesity, diet, lack of physical activity, alcohol, smoking. These lie at the core of what determines how long we live for. Now, everyday observers would probably say, surely just being healthy in and of itself is reason enough to lead a healthy existence. But alas, no. There is a need for both services to support health and ultimately public communication to remind people of the benefits and significant investment. And so we have a $130 billion health system to do just that. But Australia, as a developed economy, invests about 45% of that in just 2% of the population. And the challenge for us in trying to extend disability-adjusted life expectancy as far as we can, and we are now number 2 in the world, is that at some point we have to work out where along the life continuum is the best place to have brief interventions from professionals that can change the course of your life. But ultimately, let's not forget what public health's limitations are, because ultimately we all have to choose a door to pass through at the end of our lives. That time must come eventually. Public health may offer us a slight extension, it may improve the quality of that life, but ultimately when that time comes, those first world health expenses cannot be avoided. The need for that heart procedure, the need for the long-term care if one suffers from dementia, or those expensive treatments to slightly prolong life and reduce suffering if you contract terminal cancer. I mean, for these 3 great doors, public health is trying to extend quality of life and obviously prolong suffering as long as we can. And it sounds quite heartless as a health economist to say that what we want really is that to live a long, pain-free, productive life, but in that course of demise and decline, that we do so as inexpensively as possible. But that is the honest, laid-bare rationale behind health economics. So what do we have? We have a 4-pillared health system of MBS, PBS, public hospitals and private health that is the envy of the rest of the world. We still spend less than 10% of our GDP on healthcare but achieve outstanding results. And that is in no small part to the people who now work at ANPA. Committed professionals, as I've said before, who've worked in a number of roles before they came to ANPA, took on that opportunity because the previous government presented that to them. It just seemed that at one point, having had already APRA, and running out of acronyms, this government had to call it the Australian National Preventive Health Agency because they were running out of options. But in the 3 years they had, they committed an enormous amount of goodwill and intellectual energy to the task. So in trying to address social determinants that lie around these health risk factors, we know that we can move to education in the early years, we can look at the quality of housing, we can look at the amount of physical activity people are engaged in, we can look at a whole range of personal behaviours, but ultimately publicly funded professionals cannot kick a door in and tell people how to lead their life. So it's a frustrating job for people working in public health to try and find interesting ways into a person's life, be it the summer nats or a football game or sponsoring an app. And you can see some of these appear clumsy from the outside and sometimes wasteful. But in the end, decision makers in this chamber have to say, is the dollar best spent there, or is it best spent making sure that that old bloke can get his knee done? And we have to make sure that young children turning up to casualty are seen in a reasonable time. We have to make sure that people who need an operation for a hip can get it. And we have to make sure that life-saving surgery can continue in well-funded hospitals. And this is that terrible Hobson's choice. So in making that decision, we need to have a clear way in which we proceed. We can never stop funding a hospital. We can never stop funding the subacute that transitions people out. We can never stop funding the aged care that delivers the transition for our seniors. But we have to then work back and say, for those that regularly are in and out of our hospitals with chronic disease, who can we best support to reduce those visits to hospital, those unnecessary trips back, the surgery that goes wrong, the mishaps within hospitals that could have been avoided. And nations overseas are becoming quite vicious about the way they will not fund wasteful health expenditure. In Australia, we are privileged to have the answer to the question I've just posed. It's our 35,000 general practitioners, some of the highest trained public officials or recipients of public funding in the country, training for no less than 10 years. Their job is within 5 to 10 minutes to be able to deal with the health concerns of a concerned and often unhealthy Australian. They do it every day, all day, every corner of this country. They are the linchpin, they are the cornerstone of our health system. We must support them in every way. So, if they are working in increasingly complex team-based arrangements to share information, to identify the people that need the healthcare most, to make sure that the people who are most ill get the most time, then we need quite an elaborate and sophisticated health system to meet that challenge. If we're going to have public health interventions, they need to be cheek and jowl with general practitioners, because that is the front line. And with the greatest respect to many of us in this chamber who know no more about the health system than when visiting hours are at the local hospital, until you have worked and sat in the room with a general practitioner, you can't possibly begin to understand the complexity and the challenge of fixing this problem. And with the greatest of respect, asking people to sit at shopping centres and encourage people to go in walking groups just sets up a weird kind of adverse selection where the worried well, or the people we least need to worry about, start consuming public health resources. And it's only the general practitioner who sets up that chronic disease management plan knows that the extra time or money is best invested right there. It's the general practitioner who knows when that needs to be. With the greatest respect, we do not need to be chasing young, fit people and telling them that the way they lead their life is no good. That is simply not an effective use of public resources. I have no problem with highly expansive and elaborated primary health care and health promotion as long as we get the tertiary end right. But at present, the tertiary end is in many cases a shambles. General practitioners send their patients to a specialist. Letters come back in hard copy. There's no record available to the ambulance. They turn up at hospital and have all of their tests replicated. These most simple challenges to our health system are still in many cases beyond us. That must be our focus. We must get that part right. Now, colleagues, there is only 1 or 2% of our population that are in this category. High need, complex chronic disease patients, usually with limited resources, their entire calendar devoted to marking off when their next health appointment is. When your health calendar and diary takes over your social calendar and diary, these are people that genuinely need extra investment, because that will keep them out of hospital for longer and able to enjoy their life. It is not the focus to be putting out apps to people and counting your successes in downloads. I mean, no downloading of an app will stop a person smoking. It's the cigarettes that you don't smoke that fixes your health. We are winning with cigarettes, but there's still a long way to go with diet, with exercise and with alcohol. So let's start counting outcomes, not inputs. This is the great Labor myth. How much money we spent, how many apps got downloaded, but you know what? We never checked how many people stopped smoking. No, we didn't write that in, because if we did, we might prove the waste of money that it was. Sure, you downloaded the apps, that's exciting stuff, but nobody stopped smoking. No, they kept smoking. Australia's drops in smoking rates were under the Howard government, and the clear warnings on 30% of the front, 80% of the back, brought in by the current Prime Minister. In Australia's smoking results, I mean, they're the one positive trend that we see in public health. All of the others are potentially heading the other way. If we're designing this for Australia, we need to come right back to the general practitioner. The average GP, working full-time, 25 patients a day, 150 a week, okay, working till 6 p.m. at night, barely enough time to spend enough time with people that truly need it, and virtually no supraclinical coordination of the extra services that a GP needs to do it right. That post-stroke rehabilitation nurse, who could be in just seeing 5 of that GP's patients, needs to be easily accessible to truly make a difference. Now, they don't exist in every practice, but they have to be easily accessible to the GP. That support to help them to do their job well is what matters. You don't need a 5-storey building to do that. What you need is a care navigator sitting in the large practices, identifying the 100 most high priority patients for that extra coordination and support. That can be SMS reminders. That can be calling them back in, but not to see the general practitioner. That can be to do all sorts of health promotion activities, but let it be run through general practice. We didn't invest all this money in general practice only to set up a parallel entity, like potentially, as we will debate later this year, the role of Medicare locals. I have no problem with the staff of Medicare locals, many of them highly talented people, but they had no commissioning and no direction. They were simply unleashed by the previous government that knew so little about a health system that they figured Medicare locals would work it out for themselves. What we're left with is large entities employing sometimes over 100 people with large amounts of money in the bank, unable to spend it. And I'll do my best to stimulate again the Parliamentary Secretary down there. He has a Medicare local in his electorate and he must be genuinely concerned whether they're supporting his general practitioners satisfactorily. If we can do it, if we can connect up the information from specialists and from local public hospitals to support a GP's work, that is the essence of public health. That is what we call frontline services. Right now, we haven't had satisfactory state buy-in for a very good reason. States, historically, for the last 10 years, are slowly pulling back their services to inpatient-related work. And they're very, very happy to vacate the public health space to the Commonwealth. And that presents us a significant cost-shifting challenge. But ultimately, the Commonwealth is arguably best placed to do primary health care. We're funding the general practice system already. We're putting enormous amounts of investment into vaccination. The last thing we need are 3 levels of government trying to do all of that at the same time. The last thing we need is a large Medicare local over here and then a large community health building over here, and none of these people know what the others are doing. That is the risk of Labor monolithic bureaucracies getting involved in the health system and the millions of dollars that follow those dreams. I anticipate that the people working in both Medicare locals and potentially ANPA will find a role much closer to the front line. It's where they need to emphasise their work. If we can get the tertiary, recurrent, complex patient area right, the big savings accrue mostly to state governments. If we can reduce the need for unnecessary admissions and procedures, that'll be a saving for state governments. The problem is, in state public hospitals, there's long waiting lists, and it's effectively a ration system, isn't it? So basically, the faster they work, the quicker they go broke. So they have this enormous challenge where they need support from general practice to do everything possible to avoid unnecessary and poorly timed admissions. That can only be done if we identify our high-risk patients in every general practice, share that information with a local hospital, cooperate within that region, and then play the efficiency game and do as well as we can with those patients to reduce total health expenditure. If you get them right, and we get tertiary health prevention right for the sickest Australians, then let's return here and let's have a debate about a role for ANPA, for primary health initiatives and prevention. But right now, that money is not well spent in that area so long as we have poorly coordinated and fragmented tertiary services.